All right, I am thrilled to introduce Marcella Olson as our next speaker. Marcella is a professor of public policy at the Harvard Kennedy School and co-chair of JPAL North America's Healthcare Delivery Initiative. And she is going to give a presentation today about how to advance health equity utilizing rigorous research. So please welcome Marcella to the stage.
Thank you so much for inviting me. Thank you, Vincent, for the introduction. It's really an honor to be here. I'm quite indebted to JPAL as an institution, not only for the colleagues and the partnership, but also for the funding of high-risk yet feasible projects. And I think really importantly, the feedback on those projects at every level of ideation. In fact, I tell my graduate students and assistant professors, just apply for the feedback, because you know you're going to get incredible reviews from really smart and dedicated scholars who are truly interested in evidence. So with that, I thought I'd start with a definition. So what is health equity? This is a term that is essentially at the center of my research, and it's wonderful to see a lot of people talking about equity. And so I thought just to start us off, we'd use the definition from the CDC, which is the state in which everyone has a fair and just opportunity to attain their highest level of health. And what's interesting about that definition, as an economist, it's a state of the world, and it actually has kind of notes of Amartya Sen's idea of capabilities and having the opportunity to actually reach your individual potential. But how do you actually study health equity? How do you actually measure it? Well, what we tend to focus on is health disparities, or as an economist, you might call them gradients. And these are actually not always at the individual level. They're more often talking about sort of differences across groups, however they may be defined in health outcomes. So here's a couple of definitions. One's from Healthy People 2030, a particular type of health difference that's linked with social, economic, and or environmental disadvantaged. Here's another one from the CDC with a little bit more detail: preventable differences in the burden of disease, injury, violence, going back to Sarah's talk, or in opportunities to achieve optimal health experienced by socially disadvantaged groups along racial, ethnic, and other margins. So those both kind of intimate that we're talking about differences across different groups. And that kind of mirrors the arc of my own career. I started off as a medical doctor thinking about the individual level and then kind of moving on to the group level. Now, I also started off in development economics, so thinking about the trajectory of JPAL, looking at global health and working in sub-Saharan Africa and other places, and now have actually, a lot of my research has been focused more on North America, though I think the similarities in terms of the disadvantages that people face and their constraints and the systems that kind of oppress them, I think there's a lot of overlap there. And so we can use our econometric tools and our frameworks for thinking about it. Now, why start off with mortality rates when we're talking about health differences? Well, one reason is because it's one of the most stark outcomes, right? Obviously, dead or alive, that's an absorbing state. But also because one of the things that we have to struggle with in a country which doesn't have a universal health system is data. So our administrative data challenges are pretty profound. We don't have, either they're proprietary or they're often kind of piecemeal. But one thing we do have typically fairly complete are data on deaths. So here we can see just across the board, these are unadjusted numbers. These are pre-pandemic numbers. If we're looking at the death rate across various racial and ethnic groups, we see that the death rate for Black Americans approaches, is slightly over 800 per 100,000, where for AIAN Americans, it's close to 750 per 100,000. And then you can actually see that non-Hispanic white Americans are also actually not the lowest group. They have, they are actually beat, quote unquote, by Hispanic and Asian Americans that have lower mortality rates. And that's kind of interesting because it already starts some hypothesis generation as what might be going on there. But certainly those high numbers for Black and AIN deserve our attention. Now, if we think of mortality rates as the ultimate output, then what are some of the inputs into that? Obviously, people tend to think about insurance. And again, in the United States, we have differences. We have health disparities across racial and ethnic groups when it comes to this uninsured rate. But we can see a couple of things just from this graph starting in 2010 all the way till 2021. First, it is fairly high among Black Americans, the uninsured rate, but it's also high around Hispanic and Asian Americans. So some of those groups that actually had some of the lower mortality rates. So obviously, there's more nuance to just insured and longer life expectancy. But we also see that possibly the effects of policy and the fact that the the ACA, the Affordable Care Act, seems to come on board in 2014, bringing those lines down. And I think importantly, we see, and some of this is beyond the scope of a mere randomized trial, but you can see in Amy and Laurent's new book about insurance, We've Got You Covered, that at no point in time in this entire time series is any group looking fantastic. There's always a pretty sizable chunk of uninsured. It ranges from 5, 7, 6% to 21% in the most recent period. Those numbers are probably going to go back up with the unwinding of pandemic-era protections. And it's really just the tip of the iceberg because we're looking at a cross-section in time. So we're just asking people at this particular point, do they have insurance, yes or no? But when we think about the cumulative risk of being uninsured at any point in time, it's actually quite a bit higher. And, that's just insured. What about underinsured? What about not knowing whether the thing that you're trying to get is covered? I think that leads a lot to anxiety for a lot of Americans. And this is another slide actually by Sarah Miller and Laura Wary and Census Bureau economists. So this is kind of an interesting slide because, as I mentioned, we do face these data challenges here. This was published in Health Affairs, and again, just setting the stage. What they were able to do with their census linkage was they were able to take 2015 to 2017 ACS data, American Community Survey data, and actually look at deaths, all-cause deaths, from 2019 and 2020. So these are looking at sort of pre-pandemic characteristics of individuals, whether they be impoverished or uninsured or working in different conditions, and then looking at what that did to their death rate during the pandemic. So again, there are some data challenges still, even when you're in this restricted data center in the RDC. They can't look at cause of death, so they're just calling it, pandemic era death. But what's striking about this figure is that I think you see, first of all, you do see those socioeconomic gradients. Yes, in every group, being insured has a lower mortality rate than being uninsured. And yes, it does look like within every racial and ethnic group, higher income or more sort of conducive working conditions lead to lower mortality rates during the shock of the pandemic. But also importantly, and perhaps somewhat alarmingly, even when you condition on those things like insurance or economic status, you still see that Black Americans and AIN Americans are dying at much, much higher rates from this pandemic shock. So that leads us to a very kind of nuanced view about what actually influences health outcomes, health and well-being. So part of it are things like, jobs. That was really interesting to hear Judd's work about summer youth programs and mortality. There's great work here at JPAL with Moving to Opportunity, looking at how the neighborhood and built environment affects chronic disease, education, food, community safety, and of course the healthcare system itself. And layered on top of all of that, especially in the United States, we have a legacy of slavery and racism and discrimination that can also lead to a history of exploitation and contemporaneous discrimination that can affect health. So if we zoom in on the healthcare system and look at some of its component parts, we have this question of whether or the extensive margin of whether or not you have health insurance at a given point in time, and then of course the generosity of that coverage and whether you understand that coverage, and you're turning in and off of that coverage. We also have accessibility. So do you have a well-qualified provider? Is that someone that you can trust? Is that someone you can talk to? There's also pharmacy deserts, just like food deserts, where you can't actually get prescriptions filled. And so all of those components kind of work together, embedded in racism and discrimination, to influence overall health and well-being. So for my own career, I started off with an initial interest in medicine, clearly, and am an infectious disease doctor. I still practiced up until very recently, but then kind of zoomed out based on actually some of my early exposure to the history of medicine and to patient care, to thinking about systems and how healthcare kind of generates the inequalities that we've been documenting in this first part of the talk. So how did I make this pivot from medicine to economics? Well, actually, I was struck by this lecture that I received as an undergraduate at Harvard, but on the history of medicine, where Alan Brandt was talking about this study that had occurred for 4 decades. It's the Tuskegee study of untreated syphilis in the Negro male. That's the full title of the study, and it tells you some things right off the bat. It's going to take place in Tuskegee, Alabama. There's going to be men, black men, and they're not going to be treated for syphilis. And at the time where I was sitting, I was maybe in my post-adolescent idealistic phase, around 17 or 18. I was just shocked that this happened in the United States, that this was perpetuated by physicians, of which I wanted to become, and that it went on for 4 decades, for 1932 to 1972. So I know we were talking about replication, but this is, can you imagine a study just that long? And I remember getting goosebumps when I heard about the study, thinking that that just couldn't be possible that this occurred in the United States. But it wasn't until I became an economist that I realized that all of those things I just mentioned about the study, where it took place, who it targeted, and then this important disclosure event in 1972 by a whistleblower, could actually be harnessed for identification. And that was a study that we carried out with Marianne Wanamaker, kind of using our old school tools of causal identification, difference in differences, to understand the effect that this had. And it had a massive effect on medical distrust, mortality, and healthcare utilization. But that actually just kind of whet my appetite, because really what that meant was we were left with this incredibly discouraging, demoralizing result. Essentially, you have exploitation without apology, without reconciliation, without reparation, and then you have increases in mortality rates. Where do we go from there? And certainly our methods that we were using could not take us to the present day. It was a historical study, said and done. But it did kind of focus my attention on something that medical institutions had talked about for a long time, the American Medical Association, the AAMC, the National Academy of Medicine, as a potential remedy for those healthcare disparities, those racial health disparities that we still have in the United States, worsened by COVID-19. And they talked about diversifying the healthcare workforce, that it would be great if we had a population of healthcare providers that more nearly represented the population that we're trying to serve. And so it takes a village, and it certainly did, to actually try and actualize a test of this hypothesis that having a racially concordant physician could improve healthcare utilization and trust in the healthcare system. And that's what JPAL afforded. So they provided funding, intellectual feedback, and of course I had great partners. I had a physician on the ground in Oakland and a great graduate student as well who helped us carry out this study. We ended up starting a pop-up clinic in Oakland. I should note that wasn't by design, that was out of necessity. There simply weren't enough black male physicians existing, naturally occurring in any particular clinic for us to run this study. So that necessitated us of developing our own. And then we actually got them malpractice. So Sarah, I did a little bit of your wrangling with lawyers. I did that too to make them give us the malpractice, and then we randomized. So we randomized Black men from the Bay Area to either receive a Black male physician or a non-Black male physician, and these are pretty much the results. The beauty of a randomized trial, just a bar chart. So you can see that across the board, we have higher take-up of preventative health care. This is our high-return, low-hanging fruit health care when Black male patients are paired with a racially concordant physician. And I should say these are the second stage results. So we actually had a first stage where the men were just shown a picture of the doctor they were going to see. That didn't generate these results. Those results, you couldn't tell the difference between whether they had received a Black or a non-Black physician. So it was really about whatever magic happened in the context of a clinical room, whenever you have that rapport and that trust and that communication with your physician. And in relative terms, given the lower mean, these effects are larger for diabetes and cholesterol. And those are actually the things that required blood from the men themselves. So this to us was incredibly moving, I think, for many reasons. It's still the case that only 5% of physicians in the United States are Black. If you actually drill down and you look at maybe it's 6% now, but if you actually drill down and look at what fraction of those are US-born Black males, it's vanishingly small. So it's a really important policy problem, and I think our evidence suggests that this, and actually there's been subsequent studies as well to suggest that this is a really important issue for us to think about. How do we have a pathway for individuals to obtain medical degrees? Again, I think when COVID-19 hit, there was, it's hard to, I know it's like a PTSD when I mentioned COVID-19 hitting, but when it did hit, there was, if you remember that moment in time when everyone was saying, look, nobody's been immunized, we're all the same, nobody's seen this virus before, we're all in this together. So it shouldn't matter what zip code you live in, we're all exposed in the same way to this novel coronavirus. And that is in fact accurate, but we certainly weren't affected the same. So these are again, excess mortality rates in the US in 2020 per 100,000 by race. And again, you can see, an accentuation of some of those results that we saw earlier, just dividing across groups, where again, now Black and AIAN are experiencing much higher excess mortality due to the pandemic. So this was a time when, kind of going back to JPAL's roots with global health and international studies, we actually, and to your comments, Laura, about infrastructure, we had the infrastructure on hand. The US government was a little discombobulated at the time in terms of being able to harness, marshal, and a response. We had the infrastructure and the talent and a group of development economists, including Esther and Abhijit and many others, and a group of health economists and physicians got together and said, okay, we're gonna answer the call and we're gonna start trying to figure out what messages work well right now. And I think we just had a lot of the tools to quickly get RCTs up and running and to test things in real time. And one of the things that we took off the shelf was trying to understand, are doctors going to be ineffective? And in particular, are racially concordant physicians or ethnically concordant physicians going to make a difference as well? So we partnered with physicians from Mass General, and we created these videos. We did some in terms of a study that we wanted to actually publish. We were able to publish in Annals of Internal Medicine, showing that any message was effective in closing knowledge gaps. That's what this graph shows. In other tables, we showed that a racially concordant physician was more effective in actually getting people to link on things like how to generate your own mask at a time when we didn't have enough masks to go around in this country. But I think actually one of the most effective things that we did, we studied it, we published it in a public health journal, but I think its effect went far beyond, was that we actually were able to tell people to not travel during Thanksgiving, that very first Thanksgiving. And I felt like that was, we published in Nature, one of the Natures, and that's great. But I think the effect that we saw in mobility and the potential lives that we impacted was pretty significant as well. Okay, so that takes me to, well, what are we doing now? And it's kind of awkward to be up here because there's so much that's being done in health equity across for that, so many applications that Amy and I receive on health equity. So I sheepishly am showing one project, but there are many others there's a strong focus and interest on maternal mortality and maternal morbidity. There's a strong focus on that unwinding period that I just mentioned about how do we inform people of Medicaid availability, how to stay signed up or connect them to insurance, and so on and so forth. But what's drawn my attention is healthcare in jails, kind of bringing together the nexus of what Sarah was talking about. Now, this is a very peculiar situation, again, in the United States. I don't know how I would feel as a policymaker. On the one hand, individuals who are incarcerated have a constitutionally mandated right to health care, and that's protected under the Eighth Amendment and Estelle v. Gamble. On the other hand, there's absolutely no oversight. There's no regulation. There's only retroactive, reactive litigation. And in fact, there's an Inmate Exclusion Act. So based on the centers, when the Social Security Act was passed, you can't actually, no federal benefits can follow someone once they're arrested, even pre-trial. So you're stripped of all of your federal benefits, including Medicare and Medicaid. Okay, so in this context, and you know the numbers, these are, I don't need to tell you, it's like a conflation of a lower middle income country in a jail because you have the double burden of disease. You have communicable and non-communicable diseases. You have suicide, heart disease, and hepatitis C and HIV. And you can imagine trying to control an epidemic in that setting. So what we're doing is actually, we think it's a first of the kind. We're grateful again for the support of JPAL to take on this high risk across 44 US jails. We're randomizing them to either receive accreditation for their healthcare services through the National Commission on Correctional Healthcare or to not. And what do people predict we're going to find? Most people predict a null, that we're going to find nothing, that this is just a rubber stamp. But what I can tell you is that, in fact, and I don't know what we'll find, and we're just going to say what we find, of course. But I will say I've been surprised at how little sheriffs know about healthcare. They didn't ask to be the largest providers of mental health care in the United States. That was foisted upon them, and they often don't know what to do. And so to the extent that we think this could resolve information frictions and maybe with the subsidies that we're able to provide through JPAL, that we can actually help them out a little bit with the costs of this. They don't have to go through all the county approvals. We're just giving it to them. There might be some chance of a little bit of redemption here. So thank you so much for your kind attention. I'll leave up this slide. I really do want to say that I think that I wouldn't be in the position I am career-wise, but more importantly, I just think JPAL has been such a risk taker in a good way on projects that other people just don't see as important or just doesn't fit whatever narrative they're telling. And so I think it really helps economists make impacts, and not only at the individual level, but at the system level, and I'm very grateful for that. Thanks. I have time for questions.
Hi, thank you so much for the talk. I was just thinking about looking at the representative bureaucracy piece, if you considered healthcare providers as street-level bureaucrats, as I do, and thinking about the mental health crisis going on. Have you, in your research or any of your colleagues, considered the role of that representative bureaucracy in mental health care in providing mental health care?
Okay, so that's a great question. I wonder if you can clarify, are you talking about the mental health crisis of the patients or the bureaucrats themselves?
That's a great response.
All of the above. Well, no, I mean, it's generated by lived experience. I mean, one of the things that we're seeing, and this is also really nice, I think, obviously we're focused on the statistics and the means and the differences and how did we do our standard errors and all of that, and how, are they replicating? But I think JPAL also has been really encouraging a qualitative component to their studies. And so one of the things we've been able to add to this last one I just mentioned is and another thing that's very interesting about healthcare in jails is it's really a joint production process, and I'll go more macro in a bit, but it's a joint production between custody and healthcare, right? So you can't, even as a doctor, if you wanted to do something, you can't always because you need to get custody on board. Now, there's a name for that, and Matt and I have been kind of interested in this, moral injury, when you have a goal that you want to obtain, but you can't actually achieve it, an adaptive function, but you have some external constraint. So we've been having these conversations with inmates themselves, with incarcerated individuals, and with leadership on the custody and on the healthcare side. And the one thing that comes up for both groups, from the incarcerated individuals, I'm putting in my sick call request, I get nothing. It's hopelessness, it's despair. On the leadership side, I do not have enough staff. I can't retain staff, I can't keep staff. So enter Elizabeth Linos to help us with that problem. But that's like a huge, I think you see it on both sides. Now, we are measuring, one of our key outcomes that we're looking at for this NCCC study, we are looking at suicide. There are mental health screenings. We're looking at how well that is done in the context of a jail. And all I can tell you right now, after looking at the baseline, is that there's a lot of heterogeneity. And that's generally not a good thing in medicine. You generally want to see people going through some sort of screening process diligently, carefully, symmetrically. So that's kind of what I can tell you at a high level. Did that get to your question? Okay.
Thanks, Marcella, for this really important work. I'm Iqbal Dhaliwal, the Global Executive Director of JPAL. So one of the things that we also pride at JPAL is the generalizability of these results, right? So the racial concordance work is really important, but if I take that to my other regional offices in India or in Africa, what are the generalizable sort of lessons? Because were the results driven by this distrust because of those experiments that happened with the Black community 50 years ago? Or were there issues around, like if we take this to Africa, would tribal differentiation work? Will you take it to India, the socioeconomic or caste or gender differentiations? Did you see any of those as well? Thanks.
Yeah, like a good academic, I have to say, I don't know that it would extrapolate at all times, one for one. But here's what I think is some key kind of, conditions that, when held constant, seem to produce this sort of reaction that we've seen. One is, yes, a history of exploitation and marginalization. And in fact, what got me started on Tuskegee was the Ebola epidemic in West Africa. And all of the narratives, you would see them in the press saying, like, why can't people just not touch their dead? If they would just not follow their religious if they would just not follow their cultural practice of burying their dead, they wouldn't be susceptible to a hemorrhagic virus and propagate Ebola. Shame on them. And in fact, some very nice work, you probably know it, by Sarah Lowe's and Eduardo Montero, looking at the influence of colonial medicine and the exploitation there on willingness to take up HIV tests. Now, that's a natural experiment, not an experiment, does in fact show a very similar pattern. So when you have these, probably in the Indian context, it would be the quote unquote untouchables and things like that, or the history of forced sterility, that to think that those things just, they might fade from the policymaker's mind, but to think that they've faded from cultural memory, I think is a little bit naive. So that's where I would suspect concordance, might play an important role. Yes.
Hi, I'm Allison Sesso. I'm the CEO of RIP Medical Debt, and we handle trying to pick up people's medical debt. Interesting to look at, and a lot of studies do this, like uninsured versus insured. But what we're seeing, a lot of the medical debts that we're handling are people that have insurance, they're just underinsured. So I'm just wondering if that's an element that's being looked at, because it seems like lots of people have insurance, but they don't have enough, and what that means for this health equity question, if that's something you've been looking at.
Yeah, that's a great question. That's not an area of my focus, but I definitely think we have people in the network that are kind of leveraging, again, the unwinding right now to kind of see what happens when people fall into the gaps of health insurance. Amy, again, and my colleague, my fantastic colleague at Harvard Kennedy School, Mark Shepard, have looked at, how do we get people to enroll in insurance, and how do we get, what level of subsidy kind of works for insurance. And I definitely don't want to speak for Amy, but I think what's really exciting about where the intellectual trajectory of health economists have kind of turned recently is, we have to make this easier for people. We have to have just sort of universal default basic coverage where people don't have to know whether, get surprised with that bill because they didn't know that if they took an at-home colorectal screening, they couldn't actually go and get a colonoscopy once it popped positive. So I think I think we're kind of becoming more humane about understanding people's constraints. But Amy, did you want to say more about?
I agree with all of that. Since I'll speak for Amy for a second, I was just going to say, so I agree with what you said. I thought, Allison, your question was also about even people who have insurance, can find themselves facing large out-of-pocket medical expenses. So I think the facts that Wes Yin and Ray Klunder and Neil Mahoney and Francis Wong put together is something like there's $140 billion in medical debt held in collection agencies prior to the pandemic. That's more than all other consumer debt held in collection agencies combined. And Laurent and I calculated that 3/5 of that debt is incurred by households who are insured at the time that they're having medical expenditure. So yes, another way of saying it is that economists' love affair with cost sharing and incentives and high deductibles may have been too clever by half, at least when it comes to essential basic services that we're committed to providing.
Yeah, and I kind of jumped to, we could take a preventative approach to that and just say covered, and this is the basic, and we're all kind of covered in that same way, which might have interrupt that debt accumulation.
We have a question over here.
Hi. Kelly Bidwell, Office of Evaluation Sciences and JPAL North America alum. Quick question. I was curious for your thoughts. I've been thinking about this a lot recently, about the role of community engagement or participatory research in either in the study you just mentioned or kind of generally in this space, whether for shaping research questions or interpreting findings or setting outcomes. So would love to hear your thoughts on that.
I think it's incredibly important. Thank you for that question. And I think I've seen it change the trajectory of my own research dramatically. So for example, in the Oakland study that I mentioned, we had initially thought we were going to start by advertising flu shots, and we did focus group work, and that was absolutely not the right approach. They said, you won't get people to come at all if you say, we're going to start injecting you. So I think, and I also, we had Dr. Garrick is from Oakland. He's a respected, member of the community. He's a Black physician. So I think, institutionalizing community research when you're working with communities who have been impoverished and, made vulnerable by society in general, I think is really important, and I'd love to be part of working on institutionalizing that to a greater degree. think that's my time. Thank you for the question.
All right, thank you, Marcella, for that great talk. We are now going to move on to lunch. So lunch is served outside. Please grab your food and head back in, chit chat, connect with other folks in the room, and then we will have our keynote speak from Kim Janey starting at 12 p.m. Thank you.